Hello, I'm Nancy Rowe, and I'm really excited to be moderating today's webinar, COVID-19 and the Liver, Telemedicine during the COVID-19 pandemic and beyond. I'm pleased to mention that this is our 6th AASLD webinar, and this corresponds to the 6th update to the online document. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. The webinar is brought to you by AASLD and its over 6,700 members. Our members are instrumental in creating exceptional educational content such as this webinar tonight, and I invite you to join us. You can play a vital role in bringing liver disease and treatment to the forefront and to take advantage of the many member benefits we offer. Please visit aasld.org to learn more about becoming a member. I want to go a little bit over the agenda. So we have a pretty packed group. We have 3 great lectures in my introduction, and then we're going to have a panel discussion. We are going to wait for the Q&A until the end of the discussion. So this is our Oversight and Publication Subcommittee called COPS, and they are, for the most part, responsible for our content, and we're all listed there. This is me. I'm at Rush Medical Center, and where I'm a hepatologist. And I'm nicely joined by not only the L behind me, but also Dr. Oren Fix from Swedish Medical Center, Dr. Marina Serper from University of Pennsylvania, Dr. Elliot Tapper from the University of Michigan Health System, and then our great panelists, Laura Coolett from Northwestern, Jennifer Price from University of California, San Francisco, Andrew Reynolds, who is a patient advocate at San Francisco AIDS Foundation, Ashna Singh, Henry Ford Health System, and Nora Terrell at the Keck Medicine of USC. All right, I'm going to give you now just a little bit of the snapshot of Rush. So unlike New York and the East Coast, the Midwest was a little bit behind. We really started to feel the effects of COVID around March 16th, and our social distancing and our governor really closed all non-essential business on the 23rd of March. And so this June alert is a little bit late. We get a daily alert as to how we're doing. On June 2nd, when I had to prepare these slides, we had screened 33,750 patients. That's now up an additional 1,000 on the 4th. At that time, we had 8,545 that had tested positive and 134 admitted across our inpatient systems. That was not the peak. There were times we had nearly 300 admitted patients, but we're definitely now feeling that this is controllable and going down. At Rush's main campus, we had 110 people admitted, 44 in the intensive care unit. And then to let you know a little bit of the acuity, 29 were intubated and 7 were actually on ECMO. And again, these were not the highs of these numbers. We had also reached a pretty impressive milestone in that we had just recently extubated our 100th patient and discharged at this time 885. And we had a survival rate of 90% for all hospitalized patients, which was pretty impressive. This is a little bit of the charting that you can see that we can watch at any time. Tells us how many people are evaluated, how many required hospitalization, how many went home. And our CMO was pretty proud. On the 22nd, he put a statement out saying that we had put 18 patients on ECMO that week. And this is the same week that we successfully extubated our 100th patient. But this really didn't reflect any of the impact. And as we listened to the lectures and the Q&A today, we were pretty happy, but there was still a lot of insecurity about a lot of features of our healthcare system all through this. Part of it is what we were doing. We were all warned that we might be surged into covering COVID clinics, and that most of us were, and we were not doing our normal jobs. You can see this is the Department of Internal Medicine. Surgery was even more strongly impacted, and the volume the green line here is the number of individuals that are seen in a week in the internal medicine clinics, was over 4,000, and it went to a screeching halt to in-person visits. Although you can see here that there was a pretty rapid adaptation for both telemedicine as well as video medicine, so whether it's telephone or video encounters. And as the weeks transpired, our inpatient clinics did start to see a few more patients, and we definitely started to rely more on video consultations as opposed to telephone consultations. This is liver clinic. We saw the same precipitous drop in orange there from the patients that we normally saw to the patients that we started to not see. And then the little tiny noise at the bottom of this slide are our satellite clinics. These were much less affected, although sometimes they were affected by the availability of their provider. So if we were pulled into COVID patients, we couldn't go to an offsite satellite, but the patients were still very willing to come to an offsite where it wasn't a COVID hospital. You can see that just like the Department of Internal Medicine as a whole, our outpatient in-person visits were really quite small. And you can see this reflects all the way to May 10th, where in that week we saw 5 people in person. But our virtual visits increased. They never got back to the actual volume. We're around 70% of what we normally would see, quote unquote, see. And so we still are trying to recover. Now, it should be stated that our clinic rush actually brought back certain services first. Things like elective surgeries felt more important to get started than liver clinic. And so our actual in-person clinics were open for non-essential or non-urgent patients just this week. But you can see that even for our urgent patients, we really weren't seeing very many of them. The complexity has changed a little bit, and this is just over a difference between 5.4 to 5.5 as we started to ramp up and anticipate our clinics opening. You can see that on 5.4 on the right-hand part of the slide, most of our patients were telephone or video visits, and very few were in-person visits. That's the same when you look on the left-hand part of the slide on 5.15, but you can see that our lab is starting to open. We're starting to see more hospital follow-ups. We're starting to see a little bit of research, which had really been essentially stopped during the COVID, concerns. And I know that we'll talk a little more about it, but our no-show rate, which usually is around 16%, dropped to 5.8%. Now, there were a lot of phone calls and tracking down patients, and our rescheduled number of patients was quite high, but those that did agree to come or set up a video or televisit were incredibly punctual. So at Rush, we expected to see that this would be incredibly disruptive, but our patient satisfaction, mostly from our inpatient services, was actually still quite high. And that was despite many phone calls, social distancing, visitor restrictions. The patients that did have to come into the system were actually fairly happy with what they experienced. Not 100%, but for the most part. Our offsites were less affected, and our no-show rates changed significantly. All our rescheduling rates and probably our schedule's well-being is still quite complex, and we have not yet recovered. And so I'm going to use that introduction to turn it now over to Dr. Fix, who's going to talk about telemedicine and in more broad strokes.
Thank you very much, Nancy. Thanks for that introduction, and thank you everybody for attending. Next slide. I'm going to cover just broad definitions of telemedicine, and I'm going to talk about telemedicine generally, and I'm going to let the next speakers, Dr. Serper and Dr. Tapper, talk about telemedicine in the context of liver disease. So I'll go over some of the barriers to telemedicine adoption before COVID-19, the waivers that have allowed us to use telemedicine widely, documentation and coding issues, and telemedicine limitations. Next slide. So just some definitions. So when we talk about telemedicine, we're generally speaking about direct patient care over video or audiovisual technology that's two-way and interactive. We're usually talking about synchronous care, meaning at the same time, as opposed to asynchronous care. And that is usually considered a subset of telehealth, although the two terms are often used interchangeably. Telemedicine has lots of disciplines within it. This diagram shows telepharmacy, teleradiology, telepsychiatry, and we can add to this list now telehepatology, a new term coined by Dr. Serper. And that's certainly what we've been doing over the last 3 months or so. Telehealth is a more broad term that encompasses telemedicine, but also is involved in teleconsultation, telesupervision, teleeducation, not necessarily direct patient care. If you're familiar with Project ECHO, that's more of a telehealth rather than telemedicine enterprise. mHealth is mobile health that uses mobile technologies, apps, things like that. That is a subset of really all aspects of eHealth, which doesn't necessarily require medical consultations or education over a distance, but using electronic or technological means. What we're doing now, webinar, is probably a version of telehealth, but not telemedicine, although, like I said, the terms are often used interchangeably. Next slide. So some of the barriers to telemedicine adoption before COVID-19, why didn't we use this widely before? The most important reason is that CMS really placed a lot of restrictions on our use of telemedicine. It was restricted to patients who reside outside metropolitan statistical areas or inside rural health professional shortage areas, so basically rural patients only. And patients had to travel to a local medical facility in order to participate in the telemedicine encounter. They had to be in a physician's office, a hospital, critical access hospital, a SNF, a dialysis center, etc. And these rules were in place for many years, primarily because telemedicine was seen as a way to reach patients in rural areas who didn't have ready access to physicians or consultants, and also because internet and technology devices were not as readily available as they are now, and so patients needed to go to a center to use those devices. Next slide. The other problem with telemedicine is it's not covered by all private insurers. Not all states have parity laws requiring private payers to reimburse the same amount for telemedicine services as analogous to in-person services, which is now possible. And we're limited by technology requirements that require HIPAA-compliant audiovisual equipment, for example. Next slide. So, in medicine, it feels like people are telling us that I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years. I think when you think about your colleagues in other professions, and we see them using technology to its fullest, becoming more efficient, it feels like we've been stuck in olden times, not being able to use all the technology tools available to us to take care of patients, and that's certainly changed rapidly in the last few months. Next slide. So what changed? Well, obviously, COVID-19 changed everything. And on March 6th, Congress passed the Coronavirus Preparedness and Response Supplemental Appropriations Act, and this waived the rural area requirement and also the originating site restrictions. Originating site refers to where the patient is located at the time of the telemedicine visit. It allowed the use of phones, allowed the patient to be home. It allowed telemedicine services to be paid at the same amount as in-person services. Next slide. On March 13th, President Trump declared a national emergency, and this opened up some more doors. So HHS Office of Civil Rights announced on March 17th that they would use their discretionary ability and not impose penalties for the good faith provision of telemedicine during the COVID-19 public health emergency. And this was even if the remote communication technologies that we use are not fully compliant with HIPAA. So for example, although many of us are using HIPAA compliant technologies such as Zoom, we do have the ability right now to use things like FaceTime, which are not HIPAA compliant. And then on April 30th, CMS announced temporary increased payments for telephone visits to match in-person and video visits. So previously, telephone visits were not reimbursed by CMS, and early on in the pandemic, when it was reimbursed, it was at a much lower rate. Next slide. So there were some telemedicine interstate issues that have been really confusing. So initially, CMS said that they didn't really care where the patient was located relative to the physician's license. And in most states, providers must be licensed in the state where the patient is located at the time of the visit, which obviously isn't much of an issue when you're conducting in-person visits, but is a big issue when doing telemedicine visits. But states took exception to that and said we still want to enforce the licensing requirements, but fortunately, they made it quite easy for us. For most states are now providing streamlined emergency license applications specifically for telemedicine services during the public health emergency. And those states that aren't requiring licensing have actually stated, and this is an example of an Idaho State Board of Medicine proclamation, that you don't need to be licensed in the state of Idaho as long as you're licensed in another state. And that's true for many states. So for me personally, I've been able to get either licensed or allowed to see patients throughout the whole Pacific Northwest, working from my home in Seattle because of these new streamlined rules. For example, I was able to get an emergency license in Montana within 24 hours of a simple online application. Next slide. So documentation and coding, this is probably the boring part of this whole presentation, but I think it's important because we want to be able to get reimbursed and we want to be able to do it right. And hopefully these things will continue to evolve and make it easier for us, not just in telemedicine, but overall. But for phone visits, Medicaid and commercial codes 99441 to 443 indicate the duration of the telephone visit, and Medicare is now reimbursing for these codes during the public health emergency, and they're using the same rates as established in-person visits. But we can also use these codes and telephone visits for new patients during the public health emergency. And the documentation is pretty straightforward. You just need the total time spent with a patient and some description of your medical decision making. Next slide. For video visits, we're using the same codes as if the patient is being seen in person. So the new codes and the established codes you see there. And the documentation are the same expectations as for an in-person visit. The problem, of course, is not having a full physical exam. And it's very hard if you're coding based on E&M codes to get over a level 1 without an in-person physical exam. But fortunately, we've got a way around that. One is time-based billing, which most of these visits should be billed in that way. But next slide. The nice thing is that for video visits, CMS is now allowing us to use 2021 coding guidelines during the public health emergency. So if you're familiar with this, these are new guidelines that were set to take effect in January of 2021, but now can be used in the context of video visits during this pandemic. So for E&M coding, we no longer need to count up all the points for history and exam elements. We can just bill based on the complexity of the medical decision-making of our note, and that those rules, those points are the same as before. So it's really nice to not have to worry about all the HPI elements and organ systems. But keep in mind that still history and exam are important components that should be documented when appropriate, particularly to support medical necessity and complexity, such as in hierarchical condition categories, or HCC, a really unfortunate acronym in our field. Next slide. The other nice thing is if you're going to be using time-based coding, the new rules allow you to use all the time spent caring for the patient. So it's not just face-to-face time as we're used to, but also non-face-to-face time personally spent on the day of the encounter. And that's anything from chart prep and review all the way through the completion of your documentation. So this will hopefully capture a lot more of the work that we're doing to take care of these patients, whether they're in person or not. Next slide. So this is my last slide before I turn it over to the next speaker, and I just want to point out a few important aspects of telemedicine in general. First, there's the technology requirements, and we need to be aware that not everybody has the device that they need to conduct these visits or the reliable internet that they need. And certainly this is a lot more prevalent than it used to be. Most people do have smartphones and cell service, but not everybody. We need to be aware of that. Patients not only need to be able to have the technology required, but they need to be able to manage the technology. I'm certainly learning in my practice how hard it is for patients to just download an app or to connect to it. Sometimes they connect by video and can't manage the audio portion. A lot of our visits have been changed from a video visit to a telephone visit at the last moment because of these problems. So telemedicine is not the cure-all for COVID-19 or for the future, but it's something that we need to continue to work on. The other part of the telemedicine limitations is we're all aware that we don't have a complete physical examination. And in many cases, we're very aware that we don't need a physical examination. How many times have you seen a patient and put your hand on their belly just to make them feel like their trip all the way into the city, they're navigating traffic, paying for parking was all worthwhile just to have a face-to-face conversation with us. But now we can at least use our judgment and decide what patients need to come in because they need to be seen in person, they need a physical exam or some other in-person service, or were the patients that we can take care of quite efficiently and easily through telemedicine. But also consider not just the elements of the physical exam we're missing, but what else are we missing when we're not seeing patients face-to-face? And these are things that we're going to learn throughout this COVID-19 pandemic. I like this term webside manner to replace bedside manner, and this involves all of the etiquette necessary to conduct a telemedicine visit. Also involves the camera angle, the lighting, what's behind you, being aware of where you're looking. So looking at the camera is sort of a replacement for eye contact, but also be aware that if you've got another monitor next to you and you're always looking at that because that's where the patient record is, the patient may perceive that as you're not listening to them. And so you need to explain what you're doing. You need to introduce yourself, show your ID, make sure that anybody else in the room has been introduced. So those are just a few things to think about, and we're going to have to develop new skills to be able to use telemedicine, and we also need to be able to train our trainees in how to use telemedicine going forward. I want to touch on healthcare disparities, but we want to talk about this later in the webinar. A lot of people see telemedicine as closing the gap in healthcare disparities because we can reach more patients easier with rural patients, patients that have financial difficulties to be able to get to us. But in a lot of cases, we may be actually widening the gap because those very patients that have problems with technology or don't have access to technology are already the patients that have significant healthcare disparities already. And then finally, I want to mention sustainability. So that at the beginning of this webinar, most of you feel like you'll be able to use telemedicine in your practices going forward, but not all of that is up to us. So hopefully these waivers I've described are not going to go away, or at least will stay in some form to allow us to use telemedicine, not just because we have to, but because we want to, and we know that it's better for patient care for some of our patients, but perhaps not all. And that really remains to be seen. So with that, I'll turn it over to Dr. Serper. Thank you very much.
Thanks a lot, Oren, and thank you for AASLD for having me, and to Oren for setting the stage. Next slide, please. I have no disclosures. Next. So we're going to talk about a little bit about pre-COVID telemedicine use in liver disease specifically to start, and then I'll jump right into current use, at least in my health system. We'll talk about the current use, our telemedicine infrastructure, and then I will share with you some early patient and provider perspectives, and then we will close with potential barriers to telemedicine. Next slide. So just to jump right in, there are a couple of studies on telehealth utilization and liver disease and liver transplantation access. And most of these studies come from the VA. The VA, as you might know, is an integrated system of care and the largest provider of liver disease care in the United States that was not bound by the previous regulations to telemedicine that Dr. Fix just told you about. So a study conducted by Congetti and colleagues at the Richmond VA among 190 patients using a scan echo model, which was actually a model where hepatologists were able to train frontline providers and do case-based learning and also presentation about actual and potential patients. This model showed that among patients referred for liver transplant, those that went through the referral process through the scan echo model actually had no unnecessary or futile referrals, if you will, compared to 41% in the traditional model. And only 23% of patients through the scan echo model were ultimately not listed for transplant, compared to 56% in the traditional model. Next slide. Another study by the same group matched 232 patients evaluated for transplant initially via telehealth, again at the Richmond VA Transplant Center, and they were able to show that this evaluation cut down on the time to listing from 80 days to 22 days, and also showed that particularly patients with low MELD scores benefited disproportionately and had much shorter times to wait listing. And as you all can imagine, this is really important because our patients, even those with low MELD, can decompensate quickly in a short period of time. Next slide. This is to share with you our own local experience, now a program that's really of historical significance, even though we did it just recently. So given all the pre-COVID regulations, telemedicine, at least for non-rural patients, was part of research. And so internally, we received a Center for Innovation grant to partner with a local private GI group that generally refers to us and has 36 GI practitioners and is located 60 miles from Philadelphia to pilot a telemedicine program. This large group actually had a part-time hepatologist that fortuitously retired at the same time that we wanted to start this program. And our original intent was to provide telemedicine visits with us in Philadelphia and these patients being seen in their gastroenterologist's office within 2 weeks of a liver-related hospitalization to help manage complications and potentially reduce hospital readmissions. And we started this program in 2018 and carried on for about 18 months. Next slide. And this is just an overview. Again, the program was very simple. We did live video telemedicine. The patients would come to the to the partnering GI group's office. The MA would take their vital signs, we would do a medication reconciliation, we would do a quick AV check, and then we were able to conduct the visit. We were able to share our EHR through Epic, this interoperability function called Care Everywhere that some of you may be familiar with. And so I was able to see these patients' records live and then make recommendations. If there was something urgent, I would communicate that to the MAs. Otherwise, I would write a letter to the referring providers. And what we're able to show, and many of you have now seen this in your practice, that 94% of our visits were actually completed. 85% were video visits, and then nearly half of our visits resulted in actionable clinical recommendations that were different or in addition to what the local GI providers were offering. And the GI providers found this very helpful. 18% of our patients that we saw in the program were referred for transplant. And the other thing that we found through offering the program was that about half of the patients we saw were actually referred for a second opinion for potentially complex cholestatic liver disease, liver enzymes that were elevated without a clear cause. So they weren't all decompensated cirrhotics, but the referring practice really highly rated our service. Unfortunately, our program could not continue, so we had to stop our program right before COVID came along because we were not able to continue to give away a free service, so to speak, without a payment model, and we were severely limited. But then COVID came along and obviously the world changed. Next slide, please. And so leaders in our field, Dr. Tapper, Dr. Asrani, recently described how we can think about care redesign during COVID for liver disease and beyond. And obviously caring for patients with advanced liver disease is highly complex, and telehealth is only one piece of the puzzle, but that's an important piece to expand access to care that we will talk about more. Next slide. These are national data coming from the VA, showing you some of the data that you've already seen today, that with COVID in the first 6 weeks, total visit volumes that you see in the panel on the left in gray dropped significantly. In-person visit volumes shown in the blue line dropped precipitously, whereas telemedicine use increased by 120% in a very short period of time. And this was already in a system that was well poised to use telemedicine because pretty much all VAs have a telemedicine infrastructure. However, even with that, the telemedicine visit did not make up for all of the visits that were canceled. Next slide. And this is just another representation showing you, again, in the VA, representing 128 medical centers throughout the country, that week by week, telemedicine use went up and became nearly ubiquitous and nearly replaced all in-person visits in the first 6 weeks of COVID. Next slide, please. And so I want to share with you some of what Penn Medicine has been doing in telemedicine. Now, Penn has invested in a telemedicine infrastructure for the last 5 years or so. We have a Center for Innovation, and our leaders in our health system thought that even though telemedicine was not widely reimbursed, that it would be reimbursed in the future and it would be widely used. So in response to COVID, we have a coordinated response that we were able to rev up really quickly. And this response, as you can see, includes several concentric layers where we have symptomatic screening, we have primary care, and then we live on the inside of this circle with subspecialty care and virtual visits. And we're able to offer a variety of services through telemedicine or remote monitoring. Next slide. This is to show you the local response in the transplant center to what we call the emergent state. So we've been working very closely with our connected health IT and health team within the healthcare system. And basically what we've done in transplantation, for outpatient transplant referrals, we are continuing to see patients who have a MELD greater than 15 or have advanced HCC that we feel like could not wait. But now we have been doing referrals via telemedicine for transplant evaluations among patients with MELD less than 15 or those who have significant concerns about coming into the healthcare system. We've been doing up to 2 of these per week, and it's been working pretty well with coordination between medicine, surgery, and other ancillary services. If there's time, I can answer more questions about that. We have converted most of our routine waitlisted and post-transplant visits to telephone or video. We've been using electronic consultations within the health system to answer kind of simple curbside questions. This system actually was reimbursed since 2019, but wasn't really used. Now we're using it more. We're doing inpatient video consults for COVID patients where a physical exam is not required. And we're also using something called the virtual switchboard to facilitate automation and actually help onboard patients without having too much human work involved, if we can help it, just to increase efficiency. Next slide. This is just a couple of screenshots. So our telemedicine vendor right now, and this could change, is Blue Jeans, and it's not integrated into our EHR, but we have a freestanding switchboard that actually helps. There's a bot that actually emails and texts patients before their appointment, helps prompt them to download the software, and we've seen that 73% of patients are actually able to download the app just using the chatbot, and 40% are able to even test the app ahead of the appointment without front desk staff calling them a couple days before the appointment. So it has really dramatically cut down on the human work involved to onboard the patients, and now there's a new functionality where we can translate the messages into Spanish, and more integration is coming. The other nice thing about the switchboard is it's like a virtual room, so we're able to see when the patient logs on. It's also very helpful if we're proctoring trainees or we're working with APPs, and so we can see who entered the room and when, and you can have multiple rooms running and can proctor multiple visits at the same time. Next slide. This is to show you that our local response for advanced liver disease has really been able to maintain the visit volumes, and we've been able to convert over the first few weeks of COVID 2/3 of our visits to telemedicine, about 1/3 of them video. Now there are much more video visits, and we're still seeing about 1/3 of our patients with advanced liver disease in clinic. Next slide. This is the GI division as a whole. So this is a pretty impressive change, as you will see. So in blue, you see in-person visits, and orange is telemedicine. So again, at this point, if you just advance one more time, you see that pretty much all of our visits right now have been converted in the GI division to telemedicine. The few patients that are being seen in person are actually probably the liver disease patients. So it's really been a dramatic shift. Next slide. This is to show you that telemedicine does not function in isolation, and I think the health systems that have had success with this had a pre-existing infrastructure, and here are all the key players that have to be integrated when you have a robust telemedicine program. So obviously you have the legal regulatory partners, the clinical champions, you need to have IT support, HIPAA compliant solutions, even though right now we have a waiver. And we also, you need to have a help desk that's able to help troubleshoot issues and problems that come up from patients and from providers. And obviously it's very important to have billing and compliance in place in terms of your documentation, like what Dr. Fix was talking about earlier. And your administration obviously has to be on board with this. Next slide. So some of you may be familiar with the Rogers innovation curve, and in terms of telemedicine, we were all on the left side of the curve, those of us using it pre-COVID, and right now most of you have been kind of thrust into this early and late majority. So I wanted to show you some of the data of what do you and what do patients think about telemedicine. Next slide. Okay, so next slide. In the first 4 weeks of COVID, what we did was we polled our GI providers, physicians, and APPs. This is not just liver providers. Out of the 77 that we sent the survey to, 63 responded. And we asked them, what are your concerns about using telemedicine? Well, the biggest concern was the lack of physical exam, in addition to workflow, patient issues, technology issues. Next slide. And this just shows how the providers answered questions in terms of ease of technology download, visit quality, visit satisfaction, and whether or not they would use telemedicine. And we split this up by years in practice, just because some of our providers who had been in practice longer told us very vocally that they might have issues with technology. And what we see here is that even though some of our providers who were in practice longer might have had more difficulty with downloading the needed software, once they were able to complete the visits, greater than 80% of them were somewhat or very satisfied with visit quality and with the care that they provided, and more than 90% would probably or definitely use telemedicine in the future. And again, this is the first 4 weeks where really things were not all that well streamlined. Next slide. Here's what our patients thought. So 788 patients, about 30% answered our survey. And so I just want to show you that patients were not all that concerned about having visits with telemedicine. And again, this is the height of the COVID-19 pandemic and response. And so I think patients were grateful to have telemedicine as an option. And this slide shows you the difference between telephone and video. In general, visit quality was perceived to be as high with both modalities, as well as care satisfaction and future use. Next slide. Here I'm showing you similar data stratified by non-white versus white patients. So in general, pretty similar. However, white patients were more likely to rate their visits as good or better, and more likely to say that the technology was easy to use. However, non-white patients rated the visit quality as higher. Next slide. And this is again the same data stratified by age. Younger patients were more likely to rate the visit as good or better, thought that the technology was easier to use, which is not surprising. But overall, once they were able to connect or have the phone visit, they were highly satisfied with the care that they received and said that they would use this in the future. Next slide. And these are the top words or phrases that came to mind to our patients. Again, maybe this reflects their anxieties about not wanting to be seen in person or being concerned, but I did not edit any of their responses, and you can see that they're pretty uniformly positive about the convenience of telemedicine. Next slide. We have to talk a little bit, though, about disparities in telemedicine, like Dr. Fix alluded to. So I want to show you a little bit of data that maybe is a less idealized setting. Next slide. So these are data that come from a large, diverse clinic in UCSF and is showing early telemedicine experiences, splitting up patients into certain vulnerable groups. So what you can see in the early COVID response, the first 2 weeks or so, patients who were older than 65, those for whom English was not a language preference, and those who are Medicare, Medicaid insured were less likely to switch over to telemedicine. Next slide. And when we look at racial and ethnic minorities, patients who were white were more likely to be able to be converted to telemedicine. However, this was not the case for patients who identified as Black, Latinx, or Asian Pacific Islander. Next slide. And so here are some best practices for your own practice to help ensure equity in telemedicine, which you can't really fully ensure, but at least you can start thinking about this. You need to pay specific attention to vulnerable populations in your practice. Patients who are older, maybe hard of hearing, maybe they don't have internet, they have lower SES, they have limited English proficiency. There has to be a way to ensure and integrate high quality interpreter services. We need to be able to work to mitigate digital literacy and resource barriers, need to train the front desk staff into how to help patients download the needed software or walk them through the technology if need be. We have a bot in our health system that is able to help us with this, but we have a system that's been built for the last 5 years, if not more, and so this is something difficult to get up and running. It is also important to be very flexible to our patients when offering video versus telephone. Not everyone is able to connect via video, with the understanding, of course, there are certain physical exam features that are going to be really limited with telephone. And we need to be able to advocate for policy changes to support sustained and equitable access to telemedicine and to care in general. Next slide. And so in conclusion, the role of telemedicine was rapidly expanding, but now it's obviously exploded with lifting of regulatory and reimbursement hurdles. We have early evidence for high patient satisfaction and easy integration into clinical workflow, with the caveat that I'm presenting data from health systems that have invested in telemedicine, and this is probably not the case everywhere. And then some of these changes that we have undergone with the COVID pandemic present an opportunity for us not to revert to our previous state and really leverage telemedicine to improve care for our patients. We really have to understand how to best leverage telemedicine, what kinds of conditions, what types of patients, and what are the circumstances where it could be useful. And then we must pay attention to the unintended consequences, and we need to work to continue to reduce disparities in access to care. Next slide. These are some useful links on legislation and regulations that will also be included with this webinar. Next slide. I just wanted to thank my co-investigators on these numerous projects. Thank you very much. I will turn it over to Dr. Tapper.
Well, thank you very much. Next slide. I have some conflicts of interest which are not related to this. And next slide, I'll just get started by talking about the goals next, as move forward, of the next 10 minutes, as well as quality of care. And I just wanted to center this talk in the concept that our overarching aim is to improve the well-being of our patients with cirrhosis, and not, next slide, to simply follow the process measures of quality as if they were a checklist, although it can sometimes feel like quality it looks like that. But when something like the coronavirus happens and causes us to lose access to the procedures, tests, and visits which typically define the process measures of quality, it causes us to look for new avenues to provide care for patients, and telehealth is by far the most promising one. But it should also prompt some new ideas for how to deliver care that satisfies the aims of high quality cirrhosis care. Next slide. So before I get into some of the great aspects of telehealth that allow us to achieve the aims of quality, I think it's worth just approaching one of the threats to telehealth in the pursuit of quality. I mean, we can all agree that patients with cirrhosis should be screened for liver cancer with a combination of ultrasound and AFP, and that this is part and parcel of high quality care. Next slide. The issue is that in order to satisfy that metric, that quality measure, the patient actually has to come to your clinic, and they have to have an examination which is relatively intimate and exposes them to coronavirus or other nosocomial type of infections. And so we need to think through a way to provide effective HCC screening if we are not seeing patients in clinic. Next slide. So it's not that we can limit it. For the most part, virtually all of our patients with cirrhosis benefit from HCC screening, but the majority of our patients have compensated cirrhosis. And while I'm sure they appreciate the chat and check-in that you have with them every 6 months, the value added to coming to see you, to braving traffic, to driving 2 hours to see you, is that ultrasound that you booked 1 hour before the clinic visit. So if we are doing our visits over the phone or through video, this has a couple of risks. One, that the patient doesn't see value in the clinic and they're simply lost a follow-up. Or two, because you don't have that HCC screening as part of the workflow of new clinic visits, it may simply not get done. Next slide. So in order to ensure that we are pursuing this goal appropriately, we need to do at least two things. One, we must track our patients. We must have in our EHR robust reminders of who is due for liver cancer screening. And while many of us have that, many of us do not. And it is therefore rife with pitfalls for patients not benefiting from quality care. And then two, we have to learn to accommodate the preferences of our patients who may want to have their video or telephone visit with us, but not drive 2 hours to our clinic. And this means that we'll have to arrange more and more screening tests and procedures at local facilities for patients when possible. Now, this is okay, next slide, but it has to be considered that this is a financial threat to overall care, insofar as our clinics expect a certain revenue from these ultrasound-based visits. So if you look, here's some data from a claims-based database for largely private practices on the Eastern Seaboard. We knew, of course, that overall visits went way down with the lockdown, but there was a relatively surprising rebound pretty quickly thereafter. And it turns out, next, if you could go forward, it turns out that while many of these visits occurred over telehealth, the overall proportion of visits by telehealth plateaued and then started to slowly decrease. And the reasons for this are largely unknown, but it turns out that the majority of visits that were performed in this rebound in a broad cross-section of practices in the Eastern United States happened face-to-face. Why? Perhaps because some conversations doctors are poorly trained for to have over the phone or video visits. They're simply more comfortable having those in person. Perhaps because there are financial incentives at stake to bring people into clinic for testing. But these are the kinds of things that we need to approach to nurture telehealth, to experience all the benefits of telehealth. Otherwise, the incentives will be to bring people in. Next slide. So I believe that quality will survive in a telehealth-driven practice primarily through collaboration. Next slide. We cannot do this alone. And in fact, Dr. Shirley Cohen-Meckelberg showed in a paper that came out in Clinical Gastroenterology and Hepatology a couple of months ago that if care is concentrated in the hands of one provider, be it a hepatologist or a primary care doctor, patients with cirrhosis who were followed longitudinally in a Medicare data claims database, those people had worse outcomes. They were more likely to be hospitalized, more likely to have 30-day readmissions, and less likely to survive. But if that care was evenly distributed across primary care doctors and consulting clinicians, those patients experienced optimized outcomes. So in order to make sure that all the things we need to get done happen for patients that we may be seeing remotely, we will need to reach out and develop partnerships outside of our clinics. Next slide. This has been seen in other settings. A recent publication showed that when patients were planning to have a non-liver related surgery, those with cirrhosis experienced a 30% reduction in post-operative complications if they had a preoperative optimization visit where something like diuretics were changed. This is the kind of thing where we have to be alert and aware of in order to provide access to the kinds of visits that our patients need. Next slide. Even telehealth visits take up a lot of time, so there's probably ways to leverage economies of scale. So my boss, Dr. Grace Sue, she used the ECHO model, where in the course of 1 hour, she's able to have a conference with outlying primary care doctors who see patients hours and hours away from the referral center. They each present patients to her where she hears the basic issues or consult questions and then provides expert billable consult opinions. Patients who were seen in that clinic were matched through a propensity score to those who were not. So you had a relatively balanced severity of liver disease for people who received an echo consult or not. And that consultation was associated with an improved overall survival. Next slide. So I think that for quality to survive when we're less likely to see patients in person, we're going to need to develop those collaborative teams. But for quality to thrive, we need to do 3 additional things. Next slide. Next slide. The first one we've already discussed, and this is population health. So if you don't have a robust mechanism to track patients who could potentially fall through the cracks for their HCC screening, we're going to get into trouble if we're not seeing these people routinely. And so this is a given. Number 2, next slide, is that I think it's time to embrace the expansion of the definition of quality care. So Dr. Fasia Canwell led a group through the AASLD Practice Metrics Committee to actually codify as part of quality not only those classic process measures like HCC screening, but also validated measures of how the patient is actually feeling. And we would then judge our performance not only on how many ultrasounds we ordered and completed, but how well we addressed the lived experience of cirrhosis for patients within our practice. Next slide. We asked patients, how important are these symptoms of cirrhosis to you? And they said that confusion, itching, muscle cramps, falls, ability to avoid alcohol were almost uniformly very or extremely important. We are no longer performing physical examination. We are no longer waiting for patients to be roomed in our clinic. And therefore, we have a golden opportunity to seize this moment and start to use our time to ask what matters to the patient and to address it effectively in the course of our telehealth visit. Next slide. I don't want to get into all of these in detail, but I'll leave this up here with the webinar. But each of these symptoms has validated one-sentence questions that you could ask within 5 seconds about the burden of a patient's cramps, itching, sleep disturbance, sexual dysfunction. And all of these are, for lack of a better word, druggable targets that can be easily addressed in the course of a clinic visit. And if we view a patient's quality of life as a target for our quality, then telehealth is going to allow us to do something truly unique. Next slide. Number 3, beyond expanding the concept of quality, I think it's time to shift from being reactive to more proactive. We can all agree that we should not be screening every single person with cirrhosis for varices, but rather we use a decision rule like the Bovino criteria to find those who are at a high pretest probability of having large varices. But if the coronavirus means that our endoscopy unit might be shut down, or if it means that it's harder to clean the room, so each of those slots is increasingly precious, and if what we would actually do if we found those large varices when it was to initiate non-selective beta blockers, it could be that at the population and personal level, simply skipping screening for those high-risk patients and going right to, next slide, the use of preemptive non-selective beta blockers is a way to provide better patient-centered, cost-effective care. Now, obviously this needs more research to validate in the real-world setting, but in the context of a shared decision-making conversation on telehealth, it's very easy to ask a patient, well, I can tell you that there's risks to waiting for this endoscopy, which could be 6 or 12 months in the future. There's risks to coming to our facility, but there's also risks to starting a beta blocker, hypotension, orthostasis, but there's also benefits because randomized data has shown that if we start non-selective beta blockers for patients without varices but happen to have clinically significant portal hypertension, it reduces all-cause decompensations. Next slide. We want to prevent complications before they happen. We want to find the earliest sign of it and intervene. And telehealth is a unique way. We have these patients on the computer or in front of their phone. And if there was an app that enabled us to track a patient's weight before they developed symptomatic ascites, or track their cognitive function before they ended up in our emergency room with overt hepatic encephalopathy, then we could initiate therapy early and prevent the costly complications to the person in the healthcare system before they happened. Next slide. The issue with this, of course, is that although apps seem like a low-hanging fruit, it's actually kind of tough. So Dr. Jeremy Louis Saint, he was interested in using the EncephLab to screen for encephalopathy. So he went to a cohort in our clinic and he said, would you be interested in downloading this app and using it? And virtually everybody said that they would move forward. The problem is, next. The problem is that only 1 in 8 of those patients actually downloaded and used that app. So if we are actually interested in leveraging telehealth to prevent complications, further research is needed, but for the time being, I'll leave you with an idea, something that I've been using more frequently. Next slide. There's a validated test to assess a patient's cognitive function that is validated to predict the development of overt encephalopathy, and it's called the animal naming test. It takes 1 minute to do, and all you have to do is ask a patient to tell you how many four-legged animals they know. And if they score, if they can hardly name 15 animals, then that is a person who you would be worried about. You'd be worried, you'd want to talk to them about psychoactive medications. You may want to initiate therapy early. And this is something that can be done whether or not the video connection works. Next slide. So in conclusion, I think that this is a very unique opportunity to expand and improve the quality of care that we provide, both by focusing on collaboration and developing local resources in primary care doctors and referring clinicians, expanding the concept of quality to seize the use of patient-reported outcomes to pursue our goal of improving the well-being of our patients with cirrhosis, and favoring proactive interventions over reactive interventions. Thank you for your time.
All right, we're going to open it up now to the panel. While our panel opens their videos, I'm going to pose the first question actually to Andrew, our patient advocate. There was a comment on there about patient fear, and Andrew, I thought you might be one of the best individuals to address some of the sentiment about patients being afraid to maybe come into the medical system, or patients being afraid to use telehealth.
Yes, thank you. And that's actually a great question. I think extremely important. I really like Dr. Sarper's slides about patient perceptions of COVID during those first 4 weeks. I'm actually lucky I get to work with Dr. Andy Talal at the University of Buffalo on a project doing Hep C treatment via telemedicine, co-located at methadone programs, medication-assisted treatment programs. And it actually was very similar there. Folks really dug telemedicine. In fact, at one little study, we had like a 95% preference rate. We would prefer telemedicine to in-person visit. Folks really liked the fact that they kind of got a twofer. They were able to come in and get their Hep C treatment in addition to their methadone and substance use counseling and that type of thing. And then I think now that we're sort of in the COVID era, and certainly we're going to be in it for a while, I think, maintaining that sort of telemedicine option for patients is extremely important. I have individuals at my program at the Harm Reduction Center here in San Francisco who, they've got COPD or they've got cirrhosis and they're concerned about their own health. But then you have other folks who are like, I live with my elderly parent or my child. I don't want to risk getting something and bringing it back to them. And so I think what's really nice about telemedicine is like it sort of kind of becomes a key component to our commitment to patient-centered care. And, considering people's preferences and their expressed needs, ensuring their safety and comfort. Like these are all things that we can now provide them more so in this COVID pandemic through the use of telemedicine.
Thank you so much, Andrew. So I now have a question I'm going to pose to Jenny. There were some concerns about disparities on here, but I want you to expand a little bit on the disparities as they apply to telehealth.
Okay, great. Yeah, I'm happy to. As you already heard, I think one of the concerns a lot of us have is that as we embrace telemedicine in our clinical practice, we really need to be mindful that we may be inadvertently exacerbating healthcare disparities. And Dr. Serper discussed really well that some of our patients may have more challenges adopting telemedicine than others. So I can give you guys some examples of how we've addressed this in our own practice. At UCSF, we use Zoom for our telemedicine encounters, and it's really helpful that we can actually call interpreters on demand to join through Zoom. They can actually join the patient encounter. So it's very easy, it's on demand, it works really well, it's really user-friendly, and it's really been helpful for our patients with limited English proficiency. For the patients with limited digital literacy, our staff really spends a lot of time working with them and working with their family members to walk them through the steps of downloading the app and what the video visit would be like. And I think it's actually really helped because a lot of patients who prior to COVID said that they wouldn't be able to do a video visit now have successfully done video visits and they like it, but it takes a lot of work from the clinical staff. And then for our patients without access to Wi-Fi or to devices or even cell phones, that still remains a big challenge. For our patients who live in the more rural areas, we've arranged in some of our outreach practices for the patients to come into the outreach clinic, even if one of the clinicians isn't physically present, and the MAs there will set up the telemedicine connection for them in the clinic room, really similar to what Dr. Serper described in her practice. And then for our patients in San Francisco, pre-COVID at least, we developed a successful model of Hep C treatment delivery through video visits on a mobile van. So that's been really great because we can just park the van outside of methadone clinics or outside of a shelter to meet patients, and then we have a hotspot on the van, and the staff on the van can set up the telemedicine encounter on a laptop or an iPad. So it's been a great way for us to meet the needs of our patients living with Hep C and to improve access to treatment. So I guess what I want to say is that there's creative ways that we can use this technology, and I just urge everybody to think about how we can all try to do so to facilitate equitable access. And the UCSF Center for Vulnerable Populations actually has really great resources on the website if anybody's interested in exploring further.
Thank you so much, Jenny. It always is nice to see that something that worked before COVID translates nicely to after you get a surprise pandemic. Ashna, I'm going to put the next question to you. And someone asked a little bit about how if there's a best practice model or a way of integrating scheduled and telehealth visits. And for the panel, if any of you want to comment, please don't be shy.
Okay, guys, can you hear me okay? I think my internet's breaking up a little, so let me know if you can. But so, in terms of scheduling, we use an EMR system, Epic, which I know a lot of users on here do as well. And it's actually been a challenge to try to combine in-person visits and televisits on our calendars, because from a scheduling perspective, it's a completely different slot to have an in-person visit and a video visit slot. So actually, having done this a few times now since the state of Michigan's allowed us to start seeing people in person, doing both in-person and televisits in the same half day is really difficult. Televisits, as most of you who have done them at home now or from the office, and visits, and so if you have an in-person that's still being checked in or other things, it bleeds into your scheduled tele time. So really what we've found so far is we've assigned a half day or full day of in-person clinic to each, to providers to, per social distancing guidelines at our institution. And then we've made literally all the other visits, either telephone or virtual visits. And so far we're finding that to be really effective. So that's what we've been doing at Henry Ford.
Thank you so much. So Nora, I don't know if you're on, I can't see my lineup, but I'm going to pose this question to you. And it's about integrating the student proctoring and the mentorship of fellows. I know that you are, that may not be as smooth in your new role, but what do you envision education in this new brave world?
Well, I have to say that I was very pleased to see Marina bring this up in her talk, because I feel that going forward, we all recognize that now telehealth, telemedicine is going to be part of how we take care of patients. And we haven't in the past had a formal training of how do we train our fellows to be that kind of provider. And I think Oren hinted at the sort of, the etiquette around being a good, web-based provider. So there's so much that we really have to learn about how to do education in that way. And this idea of how can we proctor individuals as they're doing a telemedicine visit. These are all kind of the new frontier. I have to say we're not doing any of it right now. We sort of are listening in is how we do it. But I think the technology is there, and understanding how we integrate this into our education going forward is vital. I see this now as sort of standard that we have to now bring forward into the education of our up and coming physicians at all levels, residents and fellows.
So I guess that's going to lead to maybe some quality measures. There is a question that's probably best for Oren. for Elliot, and that's is there going to be, or are there already existing standardized patient and provider surveys that can help us track this satisfaction and probably even the quality aspects? I mean, I think that our view on quality is going to become very different when you're looking at telehealth or these e-visits.
You know, I saw that question and I was worried you'd ask me, but I'm sure that there are validated questionnaires for Dr. Patel. And I think those would be best used for research. And I think for one's own practice, if you're interested in seeing how well providers are doing, simply asking a patient, did you like your visit, is probably not going to be great, because they all love you and they're going to rank things very highly. So I think the key would be to ask specific questions about how things compare. Were you heard? Were you given the opportunity? Did you understand what was going on? Or did you feel that your concerns were listened to? These kinds of things. I think the more specific and your questions are, the better the information you'll get, and you're going to have to make them up yourself to suit the needs of your specific practice.
So do you think that the standard things that we already look at, such as readmission rates or the number of times you have electrolyte abnormalities, or some of the things that you've written about, are going to be translatable to the telehealth visit?
Yeah, I think so. Of course, right? Our patients still have the same needs, and I actually believe that if we're doing this the right way, that telehealth is a way of reaching a patient when they need to be seen, in the place that they need to be seen, and could very well improve the outcomes of people who need closer diuretic monitoring and the like. But if we're going to prevent readmissions, telehealth will always need to be paired with something that allows you the opportunity to escalate that visit to a place that is not the emergency room. That you need to have space in your clinic. If you're less likely to be seeing patients, converting some rooms to a kind of optimized urgent care where a nurse could see them, they could receive infusions, that kind of thing. So telehealth in and of itself is unlikely to reduce readmissions, but if it's rolled out smartly with some additional resources, it could.
Laura, so I'm going to pose a question to you. It was presented some data on using EGDs or not using EGDs, and maybe going right towards beta blockers. And then there were a couple of questions on alpha-fetoprotein and the need for an ultrasound for HCC screening, as well as a lot of emphasis that a patient with newly or existing cancer was no longer a patient that might be appropriate for routine telehealth. Can you give me your perspective in screening and management of HCC?
So in terms of screening, I have, patients have been very fearful about coming to specifically academic centers to get their ultrasound and even going to the labs. So someone had asked about using AFP. Guidelines have not supported using AFP alone because of its low sensitivity and specificity. But just if you have nothing else, you can, use an AFP. But patients have even been not wanting to go to a lab. We think that having them delay by a month or two is reasonable. However, beyond that, we start to get worried that we could be missing early cancers and would start to see a downstream effect as a result of this pandemic. So I've encouraged patients now that is now the time to start coming back, that we are being very mindful, we're being careful. The MRI department, the ultrasound department, they're distancing people, they're cleaning things. And I found that patients are now more readily accepting of this and are starting to get their scans done.
All right, we're gonna move a little bit to our last question, and I'll ask either you or maybe Nora a transplant evaluation. So it was definitely said that a patient with a high MELD maybe isn't appropriate for telehealth. But what's your opinion? Maybe that's not true. Or how do you integrate components of the transplant evaluation with still keeping your patient COVID free?
Well, maybe I'll start. I think that it's been a real it's been really, I think, eye-opening to realize how much we can do via telemedicine, even in this setting of really often patients who you typically rely on your exam and having them in the room with you, that you can do a lot via telemedicine, both to evaluate individuals who more urgently need to come in and be evaluated perhaps as an inpatient, individuals who, and where you can then stress to them the importance of them having that inpatient evaluation, or the need to transfer a patient if you're sort of dealing with providers. But I think that we've done more the individuals who are sort of referred to us, typically we'd see as an outpatient, that triaging those to determine whether they could wait versus come in now was really what we spent most of our time in this COVID era, and still are sort of slowly ramping up to sort of see who more can we see in person. So there it was all about triage. But I think in the sort of era where we're not worried about having people come into the center, there's still a role for telemedicine to help us prioritize how we put patients into our clinic, and make decisions about who can be seen in an outpatient versus an inpatient setting. So I still think it's quite valuable. Oftentimes our referrals come in with sort of sparse amount of data, and I think having the opportunity to have a face-to-face visit with the patient can help us in making those decisions. Laura?
I would agree. I have done pre-transplant evaluations using, I think the video is key, because I think you really want to see what that person looks like. I've had people stand. Can you stand, to kind of just see what their frailty is. I think it's also very important because you will then be able to say, as you pointed out, who needs to come in. And those are patients that I said, okay, tomorrow I'm going to have you come to clinic. I'm going to see you. I'm going to directly admit you so that they don't have to go sit in an ER with this COVID pandemic going on. So I do think it's going to be we will continue to do this. We'll be able to see patients that we can look at and know that they're probably not going to be a very good transplant candidate, just going through their history and bringing them to a clinic. Our clinic is a 6-hour process for pre-transplant, and seeing them on a video visit and sparing them that, or maybe getting their cardiology visit done first instead of bringing them to this long visit, I think will be very helpful for patients. So I think it's going to actually help us kind of more triage patients who need to come directly to be admitted, who can come to the transplant clinic the next week or two, and patients that we may say, we're going to get additional testing first before we bring you to this long clinic visit.
All right. I want to thank all the participants. I do want to remind everyone that the 6th update was released today to the living document on COVID management and liver disease. We definitely had an excellent panel and excellent questions, some of which we did not get to. And so stay tuned. This is a weekly event, and we hope to have a great program next week for everyone to participate in. Thank you so much.
Thank you, everybody.
Bye-bye.